And our next speaker will be Dr. A. Bhavatharani ma'am, Senior Consultant Diabetologist, E-Road State Coordinator, IMA Diabetes Course, Joint Secretary, DIPSI and TNRSSIDI. Ma'am would be talking about diabetes and CAD. Are we dealing with the human volcano? Here you go, ma'am.
Thank you, Ma. Respected chairperson, all my dear colleagues, very good afternoon. My immense thanks goes to Dr. Aarti and Dr. Arul Raj for giving me this wonderful opportunity to stand in front of you. Now my topic is, of course, sir has made my thing easy by saying so many things, but still, we just want to know what happens if both are present together. See, if you take the Indian scenario, we have about 537 million diabetics and it's spiraling out of control, and 1 in 10 people have diabetes, and half of them do not know that they are diabetic, remain undiagnosed, and the overall diabetes prevalence is increasing, and the changeover from pre-diabetes diabetes is very fast in our country compared to the other countries. And in India, the cardiovascular disease attributes to nearly 1/4 of all the deaths. And according to the global burden of diabetes, the study age standard for CVD mortality rate is 272 per 1 lakh in our country compared to 235 elsewhere. And diabetes, if you take, it's a combination of endocrine and metabolic disease leading the causing vascular lesions, and diabetes and coronary artery disease is nothing but two sides of the same coin, and having diabetes itself is a cardiac equivalent. Even if you have no history of coronary events, the goals of prevention must be maximal and equivalent to the preventive measures applied in non-diabetic persons who already have CAD. So definitely it happens to be a Volcano if both combine, that is diabetes with CAD or heart failure. And why this is so? If you see diabetes and cardiovascular disease, there is increased risk of coronary artery disease by 160% and cardiovascular death by 132%, and heart failure is 2 to 4 times more, and it is very high in women. The women are equally affected like males, so it is 4 times more in females. And I want to just remind the common soil, that is Stern introduced this common soil hypothesis in 95, stating that unlike the classical microvascular complications, the large vessel atherosclerosis, that is the macrovascular complications, precede the development of diabetes, suggesting that rather than atherosclerosis being a complication of diabetes, both conditions have the common genetic environmental factors arising together. See, both arise together with a common pathogenesis, that is inflammation and insulin resistance. It's nothing but it's same road, either side we have both the conditions. And of course, the risk factors are common for both, that is having hypertriglyceridemia, low HDL, LDL, small dense LDL, increased waist-hip ratio, hypertension, and increased BMI, birth weight is more, and other factors like smoking, alcohol, all that. The basic problem is insulin resistance. If we have hyperinsulinemia, it goes into syndrome X and causes problem. Or otherwise, if they have inadequate insulin secretion, again it causes diabetes leading to cardiovascular problems. Type 2 and excess cardiovascular CD risk runs together. That how we say in Tamil, that is the elephant comes before the bell sound comes earlier. Like that, diabetes today means heart attack tomorrow. The clock of CAD starts ticking much before the onset of clinical diabetes. And again, the thrifty gene hypothesis, that is, it has been proposed to explain the high prevalence of obesity in diabetes subsequent to metabolic syndrome in modern times. Our genetic variants, the thrifty gene, lead to accumulation of adipose stores for the preservation of nutrition and until times when it would be required. Those times we were hunters and gatherers searching in food, and we got only a single But in current times, the same protective gene has become deleterious because we get continuous food and we are storing more and more. And what are the determinant factors and characteristics of prognosis of this coronary artery disease in diabetic patient? This diabetes eliminates the protective effect of menstrual hormonal cycle in women, and there is early involvement of and past progression of the coronary atherosclerosis, and the lesion is more extensive and diffuse, involving large proportion with silent ischemia, and it has got a worse short and long-term prognosis of coronary artery disease. There is greater proportion of heart failure as well as sudden death, and worse results there with fibrinolytic treatment as well as revascularization techniques, what we heard enough from the previous speaker. And if you take in a diabetic patient with a coronary event, he has silent ischemia because of neuropathy, and you cannot find anybody with severe pain and moreover it is a multi-vessel problem with more complications, and ketosis is more common, and the PCI intervention of course is poor, and bypass is better. If you see the components of diabetes leading to cardiovascular problem, like increase in mitogen cytotoxis and as dysinsulinemia, dyslipidemia, oxidative stress, hypertension, hyperglycemia, RAS activation, the platelet activation, advanced glycation end products, tendency to thrombosis, all these leads to endothelial dysfunction throughout the body, with thrombosis, inflammation of the and causes proliferation of smooth muscles and leads to rapid and extensive atherosclerosis. And if you see the cardiovascular risk factors, those are specific for diabetes. We have microalbuminuria and massive proteinuria, abnormal platelet function, serum insulin level high, and the plasminogen activation inhibitor factor and fibrogen levels altered in diabetic. And if you say the mortality, it is very high in women compared to men. Of course, in male also it's very high, but it is 4 times high in females. And whatever it may be, either it is acute AMI or coronary artery disease or the mortality, everything is very high in diabetic people compared to the non-diabetic. And the other problem what we come across in our patient is glucose variability. This again adds fuel to the fire, causing monocyte adhesion, epigenetic modification, platelet adhesion and oxidative stress, increasing the problem further. And the other one which we should not get in a diabetics, the hypoglycemia. This causes sympathoadrenal activation, abnormal cardiac repolarization, increased thrombogenesis, inflammation, and the vasoconstriction occurring leads to cardiac ischemia, fatal arrhythmias during recognized or unrecognized episodes, because if it happens in the night, it goes unrecognized and dead in bed syndrome can happen. And hypoglycemia being shown to lower the myocardial blood flow and increases the experimental infarct size also. So with all this, can you prevent the premature cardiovascular event in diabetes? Yes, of course, if you take care of the risk factors like hypertension, obesity and dyslipidemia and stop the bad habits like cigarette and alcohol, yes, we can prevent. Or if you get the patient in a stage of hypertrophy, LVH, vascular, at least at this stage, if you treat them properly, like what Sir said in the previous lecture, definitely you can prevent the morbid events like myocardial infarction, stroke, arrhythmia and sudden death. And if you take diabetes and pre-diabetes, even pre-diabetes has a very high risk in causing cardiovascular problems. And as far as investigation in asymptomatic patients, the routine screening for coronary artery disease is not necessary if you take care of the risk factors. But in cases of atypical cardiac symptoms, like if they have unexplained dyspnea, chest discomfort, signs and symptoms of associated vascular disease like other things, that is carotid bruit, transient ischemic attack or stroke or claudication with established peripheral arterial diseases, or if you have ECG abnormalities, yes, you can go ahead in investigating for them. A special focus for microalbuminuria because it indicates endothelial dysfunction throughout the body, and you can even go see if there is abnormality in the ankle brachial pressure index. All these are surrogate markers for coronary artery disease. Resting 12-lead ECG can especially, it's very important in diabetes with hypertension or suspected cardiovascular disease. The echo or coronary artery calcium score causes high CV risk and suspected structural heart disease. And routine assessment for biomarkers, of course, it is not that necessary. The calcium artery, calcium coronary artery, this again can reclassify the disease, either it is very bad or better. And the contrast computed tomography, coronary angiography, this allows identification of coronary stenosis and adds prognostic values of calcium artery scoring. And the carotid ultrasound systemic use in the of intramedial thickness, here again this is not recommended and may be considered at a risk modifier in patients at intermediate risk. The arterial stiffness is commonly measured using either aortic pulse wave velocity or arterial augmentation index. This again predicts the future cardiovascular disease risk and improves the risk classification. The body mass index, which clearly references the body fat deposition, which can be easily measured, again shows the risk. And if you want to prevent all this in a diabetic patient, of course, this should be a multifactorial approach, gives a better outcome in 75% of cases. First and foremost is being the lifestyle changes. You have to reduce the calorie intake. You can choose any diet whichever is useful. And weight loss in obese or overweight individuals, moderate to vigorous physical activity, that is more than 150 minutes per week. Along with the A1C control, you should also look into the BP, cholesterol, dietary modifications and exercise. For example, you have to cut down the carbohydrate, go for food with a low glycemic index and glycemic load, go for complex carbohydrate intake, and rice quantity should be limited. As far as fats, it should be less than 30%, and oil rotation is very much necessary. Foods with high saturated fats must be avoided, and saturated fatty acids should form only less than 10% of the total calories, and you should avoid hydrogenated vegetable oils. Proteins, of course, 15 to 20% should form your diet, and you should also consider the other abnormalities like renal status, age, and limit red meat intake and go for vegetable source. Remember, on an average, 2% increase in energy intake from trans fatty acids, that is our biscuits, puffs and other fast food items, is associated with 23% higher coronary artery disease. So, of course, you increase the fiber intake, reduce the salt restriction less than 2.5 grams per day, and again increase your fruit servings from 3 to fruit and vegetable from 3 to 5 servings. This can reduce by 26%, and nuts 30 grams per day is associated with 30% less risk, and fish and fish oils with omega-3 fatty acids, again it's very useful. It is not that coronary artery disease, diabetes or obesity runs in your family. The fact is that no one runs in your family. See, reducing weight gives a greater benefits like reduces the total mortality and diabetes related, obesity related deaths, and reduces the systolic and diastolic blood pressure, and there is a 50% loss in fasting glucose with 10% fall in cholesterol and 50% fall in LDL, 8% increase in HDL. Remember, this is the only thing, exercise and reduction in weight is the only formula for increasing your HDL, and it also reduces the hypertriglyceridemia. The other very important thing is you should make your mitochondria green. What it means, there is a gradient difference in mitochondria color. If it is green, it is healthy. If it changes to yellow or brown, it represents a stressed, damaged or dysfunctional mitochondria. So the mitochondrial reticulum is sedentary muscle, exhibits energetic oxidative more stress, whereas if they do acute exercise, this induces further mitochondrial stress, but all the time initiates the process of removing the damaged dysfunctional regions of the reticulum through mitochondrial fission and mitophagy. So long-term exercise will improve your mitochondria. So how to treat the dyslipidemia which is associated with diabetes in order to reduce the cardiovascular risk? Of course, there is hypertriglyceridemia with low level of HDL. So there is increase in triglyceride which predicts heart disease, morbidity and mortality in diabetes, and there is preponderance of small dense LDL, though the absolute LDL is normal. And diabetes and atherosclerosis, they go hand in hand. And fenofibrate with the statins, of course, reduces the risk. The more problem is the LDL oxidation, which triggers all the vascular injury and inflammation. Then treatment about hypertension. Of course, we have many things, that is, as Sir said, thiazide diuretics, beta blockers, ACE, and calcium channel blockers. Better is you have to first go for optimal BP control. Controlling BP is very important because controlling blood sugar only controls the microvascular complication. Along with BP, it also reduces the macrovascular complication. First is, of course, lifestyle modification. BP control in diabetes requires multiple drug therapy, that is combination. ACE or ARB in patients who do not tolerate ACE is the first line, as Sir said. And in pre-diabetics, you put them on ACE or ARB, it lowers the risk of diabetes itself. So combination of ARB, it's ACE and ARB, it's not recommended. And glycemic control, try to maintain the HbA1c less than 7%. Have a strict glycemic control in the earlier. That is better because you all know about the metabolic memory and legacy effect. But at the same time, avoid hypoglycemia. In very old age, go for less rigorous target because they are more prone to get hypoglycemia. And go for cardiovascular and cardiorenal benefit drugs. You had adequate from Arulraj sir in the morning about the SGLT2 receptors and also the GLP-1 receptor analogs. And glitazones, they have been shown to increase the peripheral sensitivity to insulin and to improve the state of insulin resistance in type 2. In addition to controlling the blood glucose, it shows improvement in all the components of metabolic syndrome and certain regression of atherosclerosis also. Go for the drugs which will reduce the cardiovascular risk like our SGLT2 inhibitors, pioglitazone and GLP-1. Whereas the other metformin, DPP-4, sulfonylurea and insulin, they do not have any effect. Cholesterol, of course, statin prevents the cardiovascular and cardiovascular mortality. Intensive statin therapy is individualized depending on the problems, other problems. Of course, ezetimibe or PCIK inhibitors alone or addition to the statin improves the cardiovascular outcome and reduces the mortality. Antiplatelets, if it is diabetes and CVD together, treat like CVD disease, and diabetes with high-risk cardiovascular disease, primary prevention of aspirin is considered. In diabetes with moderate risk, aspirin is not necessary. It should be a comprehensive management. Go for lifestyle modification with proper diet and exercise, and also do a constant imaging, that is, do all the investigations and keep watching whether you are developing, and also stress management with all medications what is required. It can be a polypill like aspirin, ramipril, atostatin, beta blocker, thiazide, folic acid together. You know that childhood obesity, hypertension, macrosomia, microsomia, and the cardiovascular problem, for all that you heard in the morning, we all know that GDM is the mother of all these non-communicable diseases, and this is generated from the mother to the fetus, and there is definite transgenerational transmission of all these diseases if the mother's intrauterine milieu is not proper. So the carry-home message is the prevention of all these non-communicable diseases starts before birth. So having diabetes is as bad as having an acute myocardial infarction. Death of diabetic patient is usually due to occurring acute coronary event, even if they have other problems. Insulin resistance plays a vital role in the pathogenesis of increased risk. Coronary events are more extensive in the presence of diabetes. Management of patients with acute MI are no different from diabetic. The PCI is unfavorable outcomes, whereas CAPG is good, as Sir said in the previous lecture. Dietary and lifestyle modification are vital in reducing the cardiovascular risk. Hypertensive medications ought to be chosen which are with care in diabetics, and lipid management is slightly different from that of the non-diabetic population. Thank you.
Thank you very much, madam. She has illustrated the bird's eye view of overall view of the relationship between diabetes and cardiovascular disease. Since diabetes and coronary artery disease is a global burden, prevention of diabetes mellitus and strict control of diabetes mellitus is the most important one, and then aggressive reduction of lipids, lifestyle management including dietary modifications. She has covered almost all the points. that one more thing which I want to, the public education is more important. Rather than to prevent the diabetes and to prevent coronary artery disease, to prevent the coronary artery disease more in diabetic patient, we have to prevent the diabetes first. To prevent the diabetes, the public awareness program should be conducted often. We must enlighten about the lipids and other fast foods and other dietary modification. From the school education itself, we must teach, we must enlighten the students and the public about the risk of developing diabetes mellitus, and so thereby they are developing coronary artery disease and renal disease and stroke later on. That is the major aim of the medical professional, to publicly to educate the public regarding the preventive aspects of diabetes. Thank you so much. Thank you.
In Internal Medicine, Tamil Nadu API Chairman, for wonderfully chairing the session. I also thank Dr. Ravichandran Edwin sir and Dr. Bhavatharani ma'am for your great talk. Next, we have a guest lecture chaired by Dr. Pichumani sir, MD in Internal Medicine, DCH, Director and Consultant Diabetologist in Sri Ranga Hospital, Chengalpattu. We have a speaker, Dr. Cynthia Mohandas ma'am, MBBS, FRCP, MRCP Endocrinology and Diabetology UK, Consultant Diabetologist and Endocrinologist in Darren Valley Hospital, Kent. She will be talking